Okay, thank you. So when I was first asked to give this talk, I was asked to talk about basically lead extraction, and then when the final topic came out was how many leads, when, where and why we need to extract leads. So given the fact this is late Saturday afternoon and some of you have got a life, I thought I'd do a short version, which is how many leads, I don't know, where should it be done in hybrid OR, and why do we need to take them out, and basically infection is the answer. So if that's all you need, you can go now. I'm serious. Given the fact that there's not a lot of people are involved in cardiac lead extraction, I thought it might be a little more interesting for you though if I took you through some of the basics and then showed you what the results are like. So like many things these days, we have expert committees, and these gentlemen here, most of whom I know, are real experts. They've done a lot of lead extraction, and they've come up with a consensus for indications for lead extraction, which I think are quite reasonable, but we're not going to go through them tonight. Major complications, death of course, is always one we're concerned about, not very common however. Avulsion of major vascular structures, particularly the superior vena cava and the innominate vein, and cardiac tears are probably the things we're most worried about in terms of getting a bad outcome. And pulmonary embolism is not the normal DVT pulmonary embolism. What we're talking about there is embolus of a large vegetation into the pulmonary artery, which can cause problems. So preoperative considerations that I think are important, a very important part of the whole deal, are that you have an appropriate indication, and we'll go into those a bit later on, that you're ready for a problem. I think it should be like flying an aeroplane. It should be really boring. Nothing should happen, because like flying an aeroplane, when it goes wrong, it can go wrong very, very quickly, and you need to be prepared for it. So we need to cross-match blood, and I usually have at least 4 units available in case we get a vascular venous injury such as the superior vena cava. And that's commonly going to occur in the area that the Italians call the curve of death, which is the curve coming out of the innominate vein down into the superior vena cava and the right atrium. We need to perform some radiology preoperatively. I would normally perform a CT scan, and you need to make sure that the leads you're extracting are where you think they should be, and I'll show you some examples of that a bit later on. In patients who have had previous cardiac surgery, I like to make sure that I can perform a reduced stenotomy without any problems, and that's another reason for doing a CT scan. I also like to have thoracoscopy available in case I need to see what's going on, particularly with the SVC, and the patients are all set up, ready to go for an open cardiac procedure should that be necessary. And of course the final thing is you need to be aware of what the pacing issues are. A lot of these patients are pacemaker dependent. You take their leads out, they need to have something to keep them going, and generally speaking I would prefer to put on an epicardial lead as opposed to a temporary pacemaker, because there's a significant chance you'll dislodge the temporary device during the extraction. The risk factors for lead extraction, the ones on the left are well documented. So a lead that's been in more than 5 years is a flag that it may be an increased risk, and this is because of increased adherence, particularly to the superior vena cava and the major venous structures, but also the insulation deteriorates, and when you start putting traction on it, the whole thing can come apart. Defibrillator leads are a risk factor compared to normal pacing leads, particularly the dual coil, and basically I've given up implanting dual coil defibrillator leads now in most patients. Other well-known risks are BMI less than 25, higher New York Heart Association class 3 or 4, low hemoglobin, end-stage chronic renal failure, abnormal coagulopathy, and infection as an indication. And finally, operator experience. It's been demonstrated that there's certainly a major learning curve in the first 50 cases. The other ones that I'm concerned about are large vegetations, whether we should be taking them out percutaneously, and some of these patients I think should have the tried and true old-fashioned on-bypass, take them out safely, particularly when there's a possibility of a fungal vegetation. And the one case where I got seriously burnt in all my cases was one of these, where it was a large vegetation. The patient wasn't suitable for primary cardiac surgery because she had a platelet count of about 10,000. So we took it out. The vegetation was still largely stuck to the wall of the SVC, and while we're trying to deal with the bleeding from our cannulation extraction site, the vegetation embolized and occluded the main pulmonary artery. So I've got a bit of respect for large vegetations. Another concern would be evidence of SVC attachment. Often we can't make that assessment adequately before the operation, and it's an intraoperative assessment. And speaking to some of my colleagues overseas who have a lot of experience, this is probably where 3D echo is going to be useful. Passive fixation, usually it takes a little bit more to get the passive lead out of the ventricle, and record leads have their own particular problems. So this is the kind of problem that you would hope to identify in your preoperative echo and think about not using a percutaneous extraction, because as you can imagine, as you pull all these out through the subclavian or axillary vein, you're going to lose a lot of these vegetations into the pulmonary circulation, and if they're really quite big, they can have major hemodynamic consequences. Perforation of a lead through the right ventricle, completely asymptomatic. As you can imagine, when you pull that lead out, you're going to be left with a nice hole in the right ventricle, and that's probably going to lead to a tamponade. So it's nice to know about this before the operation. And of course, there's always someone who'll present you with a problem that you never ever expected, and here's a pacing lead down into the left ventricle. Now clearly, if you're going to take that out, you're going to be dealing with the subclavian artery, not the vein, and putting a 16 French cannula in there has got its own specific problems. In the operating room, it's important to look at the setup, the equipment that you might need, and alternative manoeuvres that may be necessary. So the patients are all set up so as that we can do a stenotomy if that's required. They have in their right femoral vein a Swan-Ganz introducer, so this is gives us the ability to give them a lot of blood quickly, and blood that's going to get up into the heart, as opposed to a cannula in an upper arm or neck vein where it may just go out through a tear that's been created. These are the mechanical dilator or dissecting sheaths that are available. There's a range of sizes, and this is basically the standard gear that we would use, and then move on to using a laser if we're not having any success with the mechanical dissectors. And I use a laser in about 30% of the cases. Other people are much more liberal with their uses, but it's using the laser has also been demonstrated to have a higher incidence of perforation. So I think it's wise to be somewhat sparing in the use of the laser. This is kind of what it looks like in the operating room. Transesophageal echo. This is the laser sheath up here coming down over the lead. The other scary thing is you see every time I tug on the lead, the CVP line moves over, which means that it's probably attached to the wall down here, and in a minute we pull back the toe and we can still see part of the defib lead here stuck. And at this point I would normally laser down to about this area and then switch over to the mechanical dissection sheath so as I've got less risk of putting a hole in something big. Essentially this is what the laser does. The laser beams come out the bottom of the sheath here, which is over the defib lead, and this is the tethering, which is schematically represented here to the wall of the vein, and the aim is to get within that area of tethering and not to get extravascular to free the lead up. So down the centre of the sheath is a locking stilette which enables you to put some traction and control on. The laser sheath goes over the outside. The burn diameter is only something like 50 microns, so it's very, very close to the position that it's applied, but it has to be applied into the right place. And of course, every now and again you may need to use a femoral approach and use something like the needle eye snare. I've only used this in 2 cases, so it's not all that common in my experience. So what are the indications for lead extraction? Well, there's infection, infection and infection basically, and then there's a few other indications. You're all probably aware of the Duke criteria for diagnosis of endocarditis. This was something that was published in about 1994, and it's basically a methodology which enables us to confirm the fact that we do have endocarditis. It looks at pathological criteria, clinical criteria with major and minor criteria, and then looks at possible disease and situations where the diagnosis is rejected. For the sake of time today, I won't go through it all in detail, but the major criteria include positive blood cultures for appropriate organisms and evidence of endocardial involvement, such as an abscess on an echo, a vegetation, or new partial dehiscence. Interestingly, new valvular regurgitation is okay, but worsening of pre-existing valvular regurgitation is not regarded as a strong sign. There are then several minor criteria, predisposing conditions such as a heart condition with a prosthetic valve or intravenous drug use, fever, vascular phenomena of emboli, septic emboli to the lungs and to the arterial system, immunological phenomena, microbiological evidence, and echocardiographic findings that don't meet the original major criteria. And that's since been added to with additional minor criteria which include a CRP above 100, presence of a central line which isn't being used for TPN, and even peripheral cannulas. This gives you some idea of these are US figures, and they're not actually being seen to parallel in Australia at this stage. So this is the rate of implantation of devices, and this is the infection rate that's being seen in the States. This is back to 2003. So a significant increase in infections and a constant increase in the number of devices inserted. Going back to the mid-90s, these authors looked at making the diagnosis of pacemaker infection, because it's not always that apparent. And if you read through this, you'll see that they basically fulfill all the Duke criteria with fever, positive blood cultures, elevated CRP. But local complications of the pacemaker, things that you can actually see externally, were only present in about 50% of patients. So even though these patients had infected pacing systems, there was only external evidence of that in approximately half the patients. And even interestingly, transthoracic echo showed demonstrated vegetations in only about a quarter, whereas TOE increased that number to pretty close to 100% when they were present. So I think it speaks volumes for having a thorough investigation of these patients, which would include transesophageal echo. What do we do about this? This is a patient that came to see me, a device implanted somewhere, obviously somewhere else, this doesn't happen to us, several years earlier, and this is what it looks like. Many people be tempted to just treat this with antibiotics. I think as we're getting smarter and we've got more evidence, we know that's not the right thing to do. And again, in 2003, this group from France again looked at presentation, and they looked at 105 patients who had signs of local inflammation or erosion of the pacemaker, all the things that make you think there might be just a pocket infection. But what they found was that regardless of the initial presentation, the intravascular parts of the lead gave positive cultures in nearly 80% of patients. So that's regardless of the mode of presentation. 80% of them had infected leads. Additionally, 90% of the cultures of the leads in the pocket, so the extravascular leads, were also positive, yet a wound swab in the pocket done at the time of surgery was only positive in 40% of cases. So basically what that says is that if you've got a pocket that looked infected, it's very likely that everything's infected. And the idea that used to be propagated years ago that you just locally excise it, wash it out and stick it beneath the muscle is probably not good enough. Some local information for you, just so as you know what's going on in Australia. This is an abstract being presented to, excuse me, it was presented at the meeting in November down in Melbourne. In Australia, the implant rate's gone up from 16,000 and a little bit in 2005 to 24,000 devices in 2013. Interestingly, over all that period of time, the indication for extraction has remained infection in about 70% of cases. It hasn't gone up, the numbers haven't gone up a great deal. If you look at it on a state basis, I'll just show you that. You can see that this is the median here for the extraction rates, either per million of population or per 1,000 implants. South Australia and Queensland have slightly higher extraction rates than the rest of us. And if you look at the indication for extraction, then in South Australia and Victoria, the indication is more commonly infection than the rest of us. The results, when they were summarised, basically show that there's been a steady state extraction rate in Australia since 2008. The number of extractions per 1,000 implants has remained steady at about 10, and for 70% of patients, the indication was infection. Even more interestingly is the complication rate for extraction was really very, very low compared to the world literature. 1.1% of patients required urgent surgery, be that drain a pericardial effusion, fix a hole in the heart, or a major venous injury, and the mortality overall for all the extractions done and this is all data collected by the lead extraction committee for the Cardiac Society, was 0.5%. And if you even drill down a bit further and looked at the top 5 extractors in terms of volume, it actually drops down to about 0.3%, I believe. So the mortality is really quite low. So with infective endocarditis, we see incomplete removal rates published somewhere between 1 and 15%. The laser has been shown to be associated with a significantly higher rate of complete removal. That's in at least 2 studies. Success by the transvenous route should be of the order of about 95%. And it's most important to remember that if you leave bits of lead behind, they are going to get sick again with infection. So the goal is complete removal, and this is a table that shows you complete removal, sepsis goes away. Incomplete removal, the patients remain or get recurrent sepsis and often die. If we look at a comparison of laser versus non-laser removal, this is a study that was the Plexus study that was published, multi-centres. Complete extraction in non-laser cases, 64%. Where the laser was used, the complete extraction rate went up to 94%, and that's a highly significant difference. The failure to get into the vein, for instance, so getting even into the subclavian vein, was much higher in the non-laser group compared to the laser group. There was, however, a slight increase in the risk of acute complications, but that didn't reach statistical significance. So I think it's important, if you're going to undertake this, that you have the complete armamentarium of devices so as you can get a complete result, particularly in infected cases. So there are other indications, such as non-functional leads or functional leads that may have a problem associated with them, leads that are causing arrhythmias, leads that have been recalled, or leads that are interfering with devices such as noise affecting defib function. You can read through that if you like, but there are other, soft indications like taking leads out because they're not MRI compatible, which are being considered. This is what one of the recalled leads looks like. So this is externalization of the cables. That can either result because the cables have worked their way from outside in, or sometimes it's due to erosion from inside out. But at the end of the day, you get the cables of the lead, which are supposed to be inside the lead, hanging on the outside. Now, it's not an absolute indication for extraction straight away, but over time, a lot of these will start to show problems such as noise, which may cause inappropriate defibrillation or failure to pace, and they need to come out. When you read through the literature to prepare a talk like this, there are a number of motherhood statements that are made, and there's nothing wrong with them, but they do kind of not take everything into account. So transvenous lead extraction for patients who do not have infection is a controversial topic, and I think that's right. It is often possible to abandon a lead that's no longer required, or to reimplant new leads through the same or an alternative route. Okay, so you're just going to leave the gear you're not using behind. And what they say here is that it's less common for patients to get symptomatic if you abandon them than if you extract them. That may be right in some centres around the world, but what it doesn't consider is that the longer you leave those leads in there, there's an increased risk if you have to take those leads out, particularly defib leads, and that risk starts going up after about 5 years. The fragility of the insulation around the outside of the lead, sometimes it starts to deteriorate, and that leads to incomplete removal. And then you got the possibility of additional complications such as thrombotic phenomena in the vein. So essentially, I think what this statement says, I'm going to leave it to somebody else and they can deal with it. And I don't know that that's an appropriate way we should be dealing with it, particularly when we look at the low complication rate that we see in Australia. Chronic pain can be an indication where all other causes of pain have been looked at and not considered appropriate. Number of leads. These are the guidelines. It's reasonable to take the leads out if there's more than 4 in one vein or 5 in the superior vena cava. Level of evidence C. I spoke to Charles Kenegran, who was part of the committee, and he said, it's just a feeling. So there you go, that fills you with a lot of faith, doesn't it? This is one of the first patients I ever saw with an SVC obstruction. 4 abandoned leads there, 2 new ones put in over here, you know, someone else's problem. Pacing dependent, severe symptoms of SVC obstruction. Every time he bent over, he nearly passed out. Every morning he woke up, his head was swollen. I took these leads out, but I'm afraid this process had been going for too long and it really didn't do him a great deal of good. So venous thrombosis, another complication. All I really want to say about venous thrombosis is that despite 40 years of experience with transcutaneous leads, no one's really been able to identify the risk factors for thrombosis. Some people say infection, others say it's due to defib leads, but that's never been shown to be true. And at the moment, we don't know why some people get thrombosed in nominate veins and superior vena cava and others don't. This is a patient that I saw with 1 lead going down from the right side that had been abandoned, a new lead placed in from the left side that was still in position, an abandoned epicardial lead, and yet as you can see here from the venogram, thrombosis of the top part of the superior vena cava. This is another patient who's got a whole host of defib leads and abandoned leads in, and a venogram taken from the left arm with the dye not going beyond the junction of the SVC and the innominate vein. So, excess leads. The role in venous thrombosis is not clear. That's why I said right at the start, I don't know how many leads, it's too many. There is a risk with these leads interfering with other functional leads, and there's got to be some kind of increased risk of endocarditis in the same way as anyone who's got a valve in their vascular system has an increased risk of endocarditis, albeit not necessarily particularly high. But I think before we take out abandoned non-functional leads, we need to really look at the risk-benefit, and that would include looking at the patient's age, how long you think they're going to be around, intercurrent disease and anticipated longevity, and the lead characteristics. In other words, is this going to be a risky extraction, or is it something that should be able to be achieved relatively easily? Tricuspid regurgitation is another potential problem with lead extraction, and I'll just go through this very quickly. This was a study published in PACE 2002, where they had 2 groups of patients where the laser was used in one group across the tricuspid valve and wasn't used in the other group, and essentially there was a slight increase in the risk of tricuspid regurgitation in the laser group, but this didn't reach statistical significance, but the authors thought that there was a trend. Another paper looked at transvenous lead extraction. Essentially what they found was that in patients where the laser was used, there was about a 5.6% risk or incidence of an increase in the TR after removal. But they didn't think that essentially it was clinically significant in most patients. What they found that in this group that had an increase in their tricuspid regurgitation, removal of more than 2 leads, power sheaths such as a laser were associated with an increased risk of tricuspid regurgitation. Another paper, however, from Roger Carrillo in Miami, who's a surgeon that does lead extraction, looked at a large number of patients where they had TOE before and after. They quantified the tricuspid regurgitation before and after the extraction, and they found that in 3 of their group of 170, that is 6%, there was TI, which was worse than it was before the extraction, but in 30%, i.e. 16 patients, the tricuspid regurgitation was actually better after the extraction, and their conclusion was that laser lead extraction was not associated with a significant increase in tricuspid regurgitation. Conclusions, therefore: infection, whether it's intravascular or pocket infection, is an extremely strong indication for lead infection, and complete removal is mandatory if you hope to cure the patient. Complication rates in Australia are extremely low, And the data's been well collected over many years by the lead extraction committee and been looked at quite seriously. And compared to the overseas rates, this is probably less than half than what's quoted in most areas. Tricuspid regurgitation, that is clinically significant, is probably a reasonable indication for extraction, though it's not yet been determined by the guidelines. And I think if you think the lead is causing regurgitation, it's probably reasonable to look at taking it out percutaneously before going on and doing anything more invasive in terms of valve repair or replacement, as Richard had discussed earlier on today. And we don't know the number of leads that mandate removal. There's no evidence to support yay or nay there. And my own personal concern, and this is echoed by many people that give talks around the world, is early diagnosis and referral without mucking around with the leads is what we would like to see. So if you think someone's got an infected pacemaker, send them to someone that does extractions. What we don't want to see are leads cut and left where they go into the vascular system where they're harder to retrieve, because you've got to get all the leads out if it's an infected case. Thank you very much.